Sure. And for full disclosure, I did have a chance to watch just a little bit of TV, but I did it with a laptop and pulled together. Oh, thank you. Pulled together what will summarize 3 hours into relatively short amount of time. So folks who are in the room with me will likely have additional things to add during the discussion. So feel free. But I'm trying to get the sort of quick gist of what was remembered, not only by me but a couple other folks who were kindly taking more beautiful notes than I was scribbling. So the first act of this two-act play was really an effort, I thought, to have a collective brainstorm around key issues within the healthcare, as well as specifically the mental health care sector. And so the major three themes that I think came again and again in the discussion was about the importance of measurement and thinking about the opportunity to have appropriate metrics at planning stages, at the stages of implementation, to provide ongoing feedback. There was a lot of discussion about the different resources that are needed. This started with reflecting on some of the plenary sessions about different streams of funding to cover services, resources in terms of the workforce that's able to deliver the preventive interventions, as well as information technology as a potential vehicle to move things along further. And then there was a lot of discussion about just the different actions that are needed within the healthcare sector, thinking about systems for implementation, systems to adapt interventions over time, systems to try and increase demand for the interventions, opportunities for evidence synthesis, and then thinking about how do we capture this ongoing local innovation. What was recognized, I think, right from the beginning is there are a number of challenges, and I think as the conversation proceeded over time, some of these were identified as potential opportunities or next steps. So right off the bat, trying to understand some of the definitional challenges, thinking about what does prevention actually mean in the different settings, thinking about different, along the continuum of prevention, what actually fits well within primary care, within specialty mental health, what can be paid for, et cetera. Thinking about what the evidence base is and what evidence is to different stakeholders is very important. There's a discussion about evidence-based practices versus evidence-informed principles, the degree to which manualized delivery of preventive interventions is the path forward versus much more principles, thinking about the gist of the evidence base and how it informs practice over time. A lot of discussion about getting information to key stakeholders, thinking about a range of types of data. On the epi side, data on quality of care. There was a note to make sure that the outcomes that are captured or measured within a system are developmentally appropriate at different stages of a child's life. There was a lot of discussion about the challenge of getting information to key stakeholders and what data those stakeholders would need, whether you're talking about state Medicaid directors, managed care organizations, quality improvement directors, and children and families, and just making sure that we don't jump over what is a big challenge of how do you fit the information to the stakeholders and what are the processes you go through. And then there was a lot of discussion about creating the business case. How do we fit existing streams of resources? How do we think about the right workforce to match the prevention programs? So there was a lot of discussion about what's helped over time. So one of the things that came out of Kelly's plenary talk was this notion of starting with a shared outcome of interest and really trying to say within the system, is there a common ground that we can reach, even if it doesn't start out as being related to cognitive, affective, and behavioral health of kids. What seems to have helped, ongoing assessment within local communities, really trying to understand local community needs and how those can be met. Thinking about new ways technology can be used, measuring fidelity, thinking about capturing epidemiologic data, think about best guiding program delivery. Use of waivers, other payment flexibility. CMMI was referenced as a place where there's a lot of natural experimentation going on within those grants that CMS provides. And then the idea of having menus, not just a single answer for what to implement at the community level or within the healthcare level, but what are menus of different options. So as we shifted into the afternoon, there was a lot of discussion about where we should go next. One of the key things was thinking about how do we invite state healthcare folks, a lot of discussion about the state being a logical focus of control. And there was a nice comment made by Kimberly about the idea of can we bring folks together and really share the headaches, right? What are the things that challenge each of us within the state system? And how is that a starting point for moving forward? There's a lot of discussion about moving much more toward engagement, thinking about community or system ownership of different interventions, thinking about building technical capacity for implementation. Again, this was seen at the state level, and there were a couple of examples given about a couple states that have moved further and could be models for others. And then there was a lot of discussion about really needing to market the impact of prevention to a whole range of audiences and in a whole range of mechanisms. So even thinking about op-eds within the local paper, thinking about using journals and meeting with journal editors to best get prevention science forward, thinking about focus groups to understand what do people want and how do we provide that. And there was a lot of discussion about fostering new measurement development. There was an idea that we need better metrics. We need better metrics to be able to make the business case for prevention. Given that often prevention has long-term gains, there was an idea of how, in the short term, how can we think about predictive proximal measures that would ultimately lead us to conclude that long-term health will follow. A lot of discussion about cost metrics, a lot of discussion of, you know what, there are existing measures, maybe we haven't thought about how to optimally use them. A couple of the NIH projects, FENEX and the NIH Toolbox, were mentioned at least as starting points. There were also a lot of other resources that were available. What was mentioned here was that there are a number of criteria that we really need to attend to if we're thinking about new or existing measure use. The specificity to the context, the healthcare setting, what's going to fit there, making sure that they're publicly available, the measures are usable, they're actionable, they're understandable, we don't want to jump over that, and then again that they're developmentally appropriate for the stage of life that one is trying to best optimize. And then we finally pulled throughout the discussion a number of things that we thought were much more cross-sectoral opportunities and how the different groups can fit together. So there was a lot of discussion about harmonization of data across sectors, the idea of creating more of a health information exchange that pulls in the same kids who may be in schools, who may in some cases be involved in juvenile justice, who are certainly within the healthcare sector, and ways in which we can't, we stop siloing off the opportunity to learn and to best manage services for folks. There was a lot of discussion about clearinghouses for evidence-based practices. There was a lot of ideas that the development of measures that have currently been deployed in health and to some degree in mental health have not necessarily been used as often in juvenile justice, foster care, child welfare. And is there a way that in a cross-sectoral fashion, we can try and bridge these different measures of health and of mental health in these other settings. And then I think a big point was the idea of understanding knock-on benefits beyond the sector. So the example was made about, in Chicago, I believe it was, the initiative to plant trees, which actually had a lot of knock-on health benefits that weren't necessarily imagined at the beginning when one was saying, how do we create potentially a safer neighborhood, a safer block? But the idea that some of these opportunities in one sector may have far-reaching implications beyond. So there was much, much more. Time is running away with us, but happy to continue the discussion after other folks go. So thanks.
That was great. I attended it, and that certainly was a good summary. But we're going to wait and hold our questions, and let's go to Shep for the school sector. Shep Kellum.